Hello, my name is Brittany Gankars, and today I'll be speaking to you about prenatal genetic counseling. So, an agenda of what we're going to speak about today, we're going to talk about the function of a prenatal counselor. I'll give you some general information about pregnancy to give you a bit of a foundation, and then we'll run through some common prenatal genetic tests that prenatal GCs deal in very frequently. Um, with anything I talk about, there's a lot of variations between counselors, between positions, between the types of tests or the specific tests that I offer or that we offer. So there's no one size fits all. I'll always try to be speaking in generalities, but don't take anything that I say to be the absolute only way to do prenatal counseling. So, if I were to write a job description for my current job, and this is a picture of the building that I work in at UConn, I would list the following things as functions for myself. I provide pre-test and post-test counseling and the coordination of aneuploidy screening, carrier screening, and diagnostic procedures. I review and analyze family and pregnancy history. I counsel patients about confirmed or suspected genetic diagnoses and ultrasound findings. I counsel patients about their options for pregnancy management, including continuing a pregnancy, terminating a pregnancy, or adoption, which is not on there, but which we'll speak about towards the end of the presentation. I also provide for emotional support for families who are having many kinds of difficulty in pregnancy. And I act as a resource for other providers. So most frequently, those other providers are the providers that I work for, or that I work with, such as the maternal fetal medicine doctors, the obstetricians, the sonographers, and the nurses. But also for community providers who call our genetics division to learn more information about a specific patient or just about genetics in general. Some of my other functions, ones that I won't get into as much today, include doing preconception counseling. So, speaking with families who come to us before pregnancy, which is sort of a prenatal counselor's holy grail. Those patients are a rare bird that we absolutely treasure. And also, in the preconception vein, counseling patients about the benefits and limits of different assisted reproduction productive options like preimplantation genetic diagnosis and in vitro fertilization. I also have educational tasks, for example, supervising learners like prospective genetic counseling students who come to us to shadow, master's level genetic counseling students like you all are, also residents and fellows who are in their sort of postdoctorate training. I'm also the associate director of our fellowship program in medical genetics, which includes coordinating monthly educational seminars for our division. And finally, one of my work extracurricular activities is that I'm part of the NICU, the Newborn Intensive Care Unit's Ethics Committee, which is called the Infant Care Review Committee. Where you can see variation in prenatal genetic counselors is that some prenatal counselors work on with a more problem-focused approach. So they'll only see those patients who have screening in pregnancy that comes back high risk or where an ultrasound anomaly is seen. And their patients will represent a more high-risk population. They might also see patients before testing, but only those patients who are of advanced maternal age. Whereas I see everyone, as young as teenagers to as old as in their mid 40s. A prenatal counselor might also be more consultative rather than integrative. And what I mean by that is that doctors might refer their patients out or somewhere else to see a genetic counselor if they don't have a genetic counselor working more closely with them or in the same location as them. So like I said, about 60% of my referrals are coming from within my own institution. The other 40% are from doctors out in the community, though. So they're referring their patients to come to UConn for either just genetic counseling or some kind of specialized testing, like some of the prenatal screening tests that I'll be talking about. Some prenatal genetic counselors might do more counseling of providers rather than patients. I don't know too many counselors who operate like this, but if you had a rural area where it was hard for patients to access genetic services, a prenatal counselor could be a really effective person to give the providers who would be more on the front lines the education that they need to best care for their patients. So there's definitely no one correct way to do prenatal counseling. I would never want you to walk away with that feeling. Some variations that we have between other specialties of genetic counseling is that as prenatal counselors, most prenatal counselors do function with quite a great deal of independence. So, for example, my sort of supervising physician in my genetics department is our geneticist, Dr. Tucker. But he's actually literally not in the building the days when I'm seeing patients. So he's not over my shoulder directly supervising everything that I tell patients. If you work in a pediatric or an adult genetic setting, you usually work more directly hand in hand with the physician than we do in prenatal, or than they usually do in cancer, just anecdotally. One other difference between prenatal and some other genetic counseling specialties is the population of people who come to you and the amount of good versus bad news that you're giving. So, most of the news that we deal out in prenatal is good news, which is a lovely thing. We do give a lot of good news, the it's a boy or it's a girl being one of those examples seen in this picture here. That is a very fun side effect of the job. And also, in terms of the people who come to us in some of the other specialties of genetics, like pediatrics, a lot of times if someone's seeing a pediatric genetic specialist, something's already wrong. Whereas in prenatal, like I said, I see a really general population. Usually, when people come to me, nothing's wrong, and things might not be going wrong. Things just may go completely routinely for my patients. So let's begin with a little primer on pregnancy. While I was preparing this talk, I put out a question on Twitter about what other prenatal counselors thought that students should know before they entered into their prenatal rotation. Because that was one thing that I was trying to keep in mind while preparing for all of you, is that I know you're on the cusp of entering your clinical rotations for the first time, which is so exciting. And if you're going to do a prenatal rotation, you are going to learn so much more from that than what you will in this talk that I'm giving today. But I just wanted to lay out a primer on pregnancy, and I was interested in hearing what other counselors on social media had to say. One person suggested watching a birth, and I can't make that happen for you today. And I actually laughed because I've never seen a birth. I don't have children of my own, so I've never given birth. I thought that was kind of a funny thing, and I don't think you need that to go into prenatal genetics, obviously, since here I am in it. But I did think that some general information on pregnancy would be really useful. So to start out with, prenatal care providers measure pregnancy in weeks. We do not talk about pregnancy in months. It's just too non-specific. You know, if you say that someone's 3 months pregnant, do you mean that they're 12 weeks pregnant or that they're 15 weeks pregnant? We just don't talk about it in months. We use weeks. So a pregnancy is 40 weeks for between the time of a woman's last menstrual period and birth. So conception happens at about the 2-week mark. So this can be a confusing point for patients that the first 2 weeks of pregnancy aren't real. Conception hasn't happened yet. So when we're measuring from a last menstrual period, conception doesn't happen until about week 2, which is when, ovulation occurs and a woman's fertile. So no one's ever really 1 week pregnant, and by the same token, a week after our periods, all women are essentially 1 week pregnant. So conception's happening about the 2-week mark when we measure from the last menstrual period, or the LMP. And as you may be picking up on so far in your training, medicine is really just an alphabet soup of acronyms. So we'll try to introduce you to some of them today. A woman's missed period, so usually a woman's first indication that she is pregnant, happens at about the 4-week mark. So that 4-week mark is kind of on the earliest end that you'd be finding out you are pregnant. Sometimes women who are really trying to get pregnant will find out around the 3-week mark or a little earlier than that. But that missed period happens around week 4. And then around week 8 is when most patients will have their first appointment with their OB doctor, the provider who will be giving them care during their pregnancy. And you may also hear pregnancy talked about in trimesters, first, second, and third trimester. So there's that as well. Viability, or the point at which a baby can survive if born, happens around 24 weeks. Hopefully not near 24 weeks, because we would definitely like them to get to that 40-week mark. And at the 40-week mark, that's when a woman gets her due date, which we also call the EDC, which stands for the estimated date of confinement, which I know sounds a little bit medieval. But that EDC will be the mark about 40 weeks after her last menstrual period, or when she's dated by ultrasound, which is the more accurate way to date a pregnancy in the first trimester. And where most of the magic happens for us is between about 10 and 24 weeks. So this is when most prenatal genetic counseling is going to take place. This is when all or most of our genetic screening and testing is going to take place. It's pretty rare that I see someone before 10 weeks of pregnancy, though there are exceptions. Just yesterday, a former patient reached out to me that she was 7 weeks pregnant and wanted to make contact with genetics right away because she and her husband are carriers of spinal muscular atrophy. So they would like to get in as soon as possible to do prenatal diagnosis for that condition. So sometimes we touch base with patients very early in pregnancy. And occasionally we'll see patients in the third trimester of pregnancy, maybe patients who were late to getting obstetric care, or patients where there's ultrasound findings that are seen in the third trimester or late in the second trimester of pregnancy. But generally, our counseling is happening between about 10 and 24 weeks. And if you want to date someone's pregnancy, this right here is your new best friend. This is a pregnancy wheel. So using this, you can get someone's gestational age, you can calculate what someone's due date would be using either their last menstrual period or an ultrasound gestational age, or you can work backwards, putting in their due date and using that to see what their gestational age is. When you're in prenatal clinic, you will definitely see these, probably a lot of them. So I just wanted to give everyone an idea of what someone's care might be like in pregnancy. Some of the examples of care providers that can follow women through their pregnancies are, of course, obstetricians. And in my area, this is the most common option that women go to for prenatal care. But a woman might also be seen by a midwife or a family medicine doctor. And there are women who don't present for care during pregnancy, who don't have any consistent prenatal care. No one can make you get consistent prenatal care. If you want to, if you want to go give birth in the woods or with dolphins in the ocean, that's your prerogative. But those are probably people who won't present for genetic screening either. And usually, like I said, the first appointment is around the 8-week mark. Of course, I know I've said this before, but this is all just really general information. This could vary from person to person or practice to practice. And then for the most part, you're going to be seeing a doctor about every 4 weeks for the majority of pregnancy until about the 28-week mark. And then your visits are going to get a little more frequent. They'll go to once every 2 weeks for a while. And then by the end of pregnancy, after 36 weeks, they'll go to once a week. So you're sort of increasing in frequency of getting care from your doctor the closer that you get to birth. And then these are some points in a pregnancy where we might do some imaging, like ultrasound. Oftentimes, the first ultrasound that people will have, at least in my area, will be a dating ultrasound. And with the doctors that I work most closely with, this is something that they do at the patient's first appointment for the pregnancy. They do an ultrasound around 8 weeks to establish or confirm the EDC, or the due date. And I put some corresponding pictures of these ultrasounds down here as well. Oftentimes that first ultrasound, that 8-week ultrasound, it is a transvaginal ultrasound and not an abdominal ultrasound. So that can be something patients are a little unprepared for. One of my patients once said, and then they said, take your pants off. And I thought, I didn't expect this. And then between 11 and the end of 13 weeks, we do a 12-week ultrasound, which is where some genetic screening happens to look at the nuchal translucency. And I'll talk in much more detail about that before the end of this talk. And there's a little 12-week fetus there. Between 18 and 20 weeks is an anatomical survey. And that's where we evaluate the anatomy, going from head to toe or toe to head, looking at all the organ systems to see how they're growing and developing. That's the most thorough look that we'll be getting of a baby's body during pregnancy. And as we've been, moving along from the past to now, ultrasounds have been getting more frequent in pregnancy. So for example, when my mom was pregnant, people usually only did one ultrasound if they did any, and it was usually this 20-week anatomy ultrasound. Now, because we have better imaging, we do earlier ultrasounds to confirm dates and do screening, but this anatomy ultrasound's been around for a while. Patients or lay people might think of this anatomy ultrasound as the ultrasound where you can see the sex of the baby. But that's definitely not why we do the ultrasound. And this is the ultrasound from a prenatal counselor's point of view, where we would be seeing things like major birth defects. So even though we're doing ultrasound at to earlier points in pregnancy, the fetus is very small at that point. So at the time of the nuchal translucency ultrasound, you're only about 5 to 7 centimeters long. So any birth defects like congenital heart defects or spina bifida usually won't be able to be appreciated at that ultrasound. So it's that 20-week ultrasound that gives us that information about the structure of the baby's body. And then around 22 weeks of pregnancy, a patient may have an ultrasound called a fetal echo, which is an in-detailed look at the fetus's heart. And it's done at this later point in the second trimester because that's when the heart can best be visualized. So in this ultrasound image here, you can see the 4 chambers of the heart. This is kind of like as if you were cutting right through the chest. You can see the heart here, and they look at the structure of the heart, the veins and arteries going in and out of the heart. They look at how the blood flows. And it's at this point in gestation that they can get the best look at that. So most patients won't have a fetal echo in pregnancy. Some patients who might are patients who are at increased risk for congenital heart defects, such as patients who have diabetes or patients who've had a child with a congenital heart defect. In our center, all the patients who've done in vitro fertilization have fetal echoes. And then if we are suspicious of a genetic diagnosis, or if we've confirmed a genetic diagnosis like Down syndrome, fetal echo is a tool to look at whether there's a cardiac defect. From this picture of the anatomy ultrasound, if you can see here, this is a cute little profile, and you can see the baby's arm and hand is up by his or her face. So we look at cardiac anatomy with that fetal echo. And then you may wonder how the 3D imaging that's so popular right now, where this all fits in. Most of the time when you see 3D images like this one, where you've got this like chubby little baby face, those are usually happening in the 3rd trimester of pregnancy. The earlier you do 3D imaging, the more alien-like the baby will appear. So those like cute baby pictures are usually from people going in their 3rd trimester, a lot of times going to places that offer recreational ultrasounds. So ultrasounds where their goal is not to do a medical evaluation, but rather just to give the parents a show. And sometimes it's a cute show, like this picture. From a medical point of view, 3D ultrasound is a really powerful tool in terms of assessing for things like birth defects, or if we suspect there's a problem, to get us more images. It's a great tool for evaluating the face if we're suspicious of something like cleft lip and palate, which you can see in this 3D image here. So we're seeing a unilateral cleft lip on this baby. And then at what points in pregnancy are we getting our genetic tests? Are we getting genetic testing? There's a lot of different options for genetic testing in pregnancy, and I'm going to cover some of those options today. And they happen, like I said, mostly in that 10 to 24 week mark of pregnancy, usually not. Before 10 weeks, we really don't have genetic screening that is available yet. And then after 24 weeks, the genetic screening is usually over by then because the options for management really narrow after 24 weeks. So we're doing most of our genetic screening in the 1st and 2nd trimester. So in the 1st trimester, some of the things we have are evaluations like nuchal translucency and 1st trimester serum screening. We also have chorionic villus sampling, which is a diagnostic test I'll talk more about. In the 2nd trimester, we have 2nd trimester serum screening and amniocentesis, a diagnostic test. And then after 10 weeks, and then sort of with less limitations on the timing, we have cell-free DNA testing, which I'll definitely talk more about today, and then also carrier screening. And carrier screening really knows no gestational age, because you don't have to be pregnant to have carrier screening at all, but we try to do carrier screening earlier rather than later in pregnancy. And what's the genetic counselor's role in all of this? We're providing education for families, we're providing support, we're providing coordination of the testing options that they choose, and we're providing individualization. So we're recognizing that one size does not fit all when it comes to genetic screening in pregnancies, and we're helping patients make the best decisions for their family consistent with their values and based on what information would be useful for them. So most of my initial genetic counseling sessions are to provide education about aneuploidy screening options and to offer patients testing. So in my practice, and of course this will be very different from place to place, in my practice I see patients after they've had their 12-week nuchal translucency ultrasound. I see them immediately after. So they have their ultrasound and then they come and speak with a genetic counselor to go through what their options for testing are. And what I do is I offer them and educate them on maternal serum screening, cell-free DNA testing. We talk a bit about diagnostic testing like CVS and amniocentesis, and I might offer them carrier screening. I also review their family history at that time to see if there's any other concerns that we can discuss while I have them with me. And in prenatal genetics, our family history tends to be focused on things like birth defects or intellectual disability. Anything that someone brings up in family history with me is something I'm willing to discuss with them. But that's sort of our lens that we're looking through when we take family history, is things that might affect the fetus, or things where we might change some of the patient's surveillance during pregnancy. So sometimes you get patients who come in overflowing with family history and they want to tell you about everyone's adult onset diabetes and everyone's, like, their great aunt's bunion. But what we're after is sort of more an early life focus with the family history. So some of my family histories look pretty short. I don't take a full 3-generation pedigree for everyone. If someone doesn't report any concerns in their family history, then my pedigree is only 3 symbols, square, circle, diamonds. That's sort of the simplest family history you could have in prenatal genetics. When the patient chooses to go forward with testing, I facilitate that testing. So I coordinate a lot of the logistics of that. Discuss with them how they'll get results, what they can expect from results disclosure, and then when their results do come in, I'll disclose results to them and do any necessary follow-up that comes after that. So like I said, that's kind of our take on prenatal counseling, and that's how we end up seeing really almost all of the pregnant patients who come through our institution. Um, and there's different ways of doing it. You know, some of the benefits to this is that when patients do get high risk results, they have already met a genetic counselor and we've sort of established a rapport and a relationship with them, so that then when they need to navigate murkier waters, it's with someone that they've met before. And we're also getting that chance to review family history. Something that you might find as you go to different clinical sites and train is that genetics professionals look at family history differently than a lot of other care providers. So things that other providers might sort of like blow off, we will work through those with a little more care. Multifactorial conditions are a great example of that. So if someone tells me that they have a lot of family members with diabetes, we'll get the chance to talk a little bit about how there's genetic and environmental factors to diabetes. And so while it doesn't move through families in predictable patterns, someone might inherit a predisposition to developing adult onset diabetes. Not that other providers never talk to patients about that, but rather than just saying, like, oh, that's not genetic, first of all, never ask a genetic professional if something's genetic, because at least my answer is almost always going to be yes. But it's nice to have that time to go through family history and get any of the patient's questions answered. Even if it's just about simple things like, my other children have ADHD, will this baby have ADHD too? So things that, just because they don't directly impact the pregnancy management, they might still be factors that are really important to the patient. And if it's a factor that's really important to the patient, then it's really important to us too. So first we'll be talking about nuchal translucency and first trimester serum screening. So, to begin with nuchal translucency, this is an ultrasound that's happening, or a marker on ultrasound that's happening between 11 and 13 plus 6 weeks of pregnancy. This is a really specific ultrasound measurement, and there's actually a certification process that the sonographer and physician go through in order to measure nuchal translucency. And what that is a small fluid filled space that's under the fetal skin at this time point in pregnancy. And as the fetus grows, that fluid filled space is going to go away. It's just going to become the skin at the back of the neck. So that's why this needs to be measured during a really specific time during pregnancy. At this time, some centers will also look for the presence of the nasal bone. Sometimes that gets incorporated into first trimester screening. Oftentimes it does not. But that's the little bone that happens right at the bridge of the nose. That's seen in most fetuses at this point, but in fetuses with Down syndrome, it's more likely to be the nasal bone's more likely to be absent. So, what a normal nuchal translucency is one that's smaller than 3 millimeters, and they're almost never smaller than 1, just because they're not. And an abnormal nuchal translucency is one that's great, or I think I might have said centimeters before, I meant millimeters. An abnormal nuchal translucency is one that's greater than 3 millimeters. So I love this schematic because I love how it shows cartoon alien baby along with the ultrasound picture. So you can see how on the normal side of things, we're just seeing that very thin fluid-filled space behind the neck. They use a green line on the ultrasound picture to denote what that is. And then that corresponds to just a thin fluid-filled space behind the neck of the fetus in the cartoon baby. Whereas when it's thicker, it's kind of a thicker pocket of fluid that's behind the fetal neck. So kind of a little extra pouch of fluid. And something that can be difficult for some patients to get their head around is inherently that's not really a problem. So it's not like that pouch of fluid is going to persist until birth, especially if it's only a little bit increased over that 3 millimeter mark. The problem is what that might mean for the fetus. So if we see a large nuchal translucency, that raises the risk for chromosome conditions like Down syndrome, but also the more rare aneuploidies like trisomy 18 and trisomy 13. It raises the risk for more rare chromosome conditions, ones that aren't in those big 3. It also raises the risk for things like congenital heart defects. So when we see a patient with a large nuchal translucency, we refer them for a fetal echo as well to look at the fetus's heart. And then larger nuchal translucency has also been associated with more rare conditions. And if you pull a paper on all that it's been associated with, the list is very, very long. And I'm definitely not going through that whole list with all the patients who are seen to have this on first trimester ultrasound, because it's been associated with some really rare things, in addition to more common things like Down syndrome. So when we see something like this, then we can offer patients both further options non-invasively for evaluation, like the cell-free DNA testing that I'll be talking about in a bit, or diagnostic tests for evaluation, such as chorionic villus sampling or amniocentesis. And just because we see an enlarged nuchal translucency, it doesn't mean that something's definitely wrong. And in fact, most of the time, something's not wrong more often than there is an actual diagnosis. So helping patients understand that, what it means to have an increased risk versus a diagnosis is one of our roles as genetic counselors. And also not sort of overselling how high that risk is. So appreciating with the patients that everything still might be okay, but that this is showing us that there's a higher chance. Is sort of the balance that we strike. So along with nuchal translucency, particularly when we have a normal nuchal translucency, there's a couple options for maternal serum screening that a patient can pursue. And I'll start by talking about serum screening in general. One of the things I'm interested in when thinking about you all as training genetic counselors is how much you're going to deal in serum screening in your careers and how much of this detail you're going to need to know. Since serum screening is really starting to fade and become much less popular with the advent of cell-free DNA testing, which I'll be talking about. And basically, serum screening is blood work to assess hormones or protein markers from maternal blood, and then using patterns of those hormones, sometimes in combination with ultrasound markers like the nuchal translucency, to assess the risk for common aneuploidy like Down syndrome and trisomy 18. So, serum screening has a really long history. It began in at least the 80s with AFP screening and has gone through about dozens of variations since then. And even now, currently, there's a lot of different flavors or varieties of serum screening that you could do. You can do first trimester screening, which I'm going to talk about in more detail on the next slide. You can also do sequential screening, which is a combination of first and second trimester screening. You could do integrated screening, which is also a combination of first and second trimester screening, but has a little bit of a twist to it. You can do second trimester screening alone, which now would also be called a quadruple or a quad screen. And then you can do a serum screening with MSAFP alone to screen for things like spina bifida. And I'm going to talk a little bit more about the second trimester options when I talk about the second trimester tests. So I'm really interested to see how much you'll all end up knowing all the details about these screens as you start your careers versus when I started mine. So in first trimester screening, like I said, we're measuring levels of hormones in maternal serum. And what these hormones do is essentially meaningless for the purposes of first trimester screening or for serum screening in general. But what we're looking for is the amount of these hormones because it was observed that pregnancies with aneuploidy tended to have particular patterns in the amount of these hormones that when they were measured. So in first trimester screening, we're measuring generally two hormones. One of them is HCG, which is the hormone measured in pregnancy tests. Another one is a hormone called PAP-A. And like I said, what these things do aren't important for this purpose. PAP-A stands for placental associated protein P, which essentially means we have no idea what it does. But what we do have pretty well established is that pregnancies with Down syndrome tend to have a pattern of having high HCG and low PAP-A, whereas pregnancies with a more rare aneuploidy like trisomy 18 tend to have very low values of both of these hormones. And these hormones are produced by the placenta. And keep in mind that for a pregnancy with a chromosome condition, the placenta also has that chromosome condition. So looking at those placental hormones can give us information about the overall health of the pregnancy. And then the risk based on mom's age is also incorporated into this. For serum screening, this is used as the a priori or the starting risk for the screening. So we start with the risk based on mom's age, we add in the measurement from the nuchal translucency, and then we add in the quantities of these two hormones. And what that produces on the results ends of things is the risk or chance for either Down syndrome or trisomy 18. And that risk is typically presented like a fraction or a ratio. So in this sample report, this is a really normal result. What this is showing in this horizontal column under Down syndrome is what the patient's age-related risk was, so what her starting risk was. For example, if she was 35 when her baby would be born, her starting risk would be a 1 in 270 chance. And then it shows that after her screening, her result or her final risk is a very low risk. So this is showing it, you might not be able to see this small. This is also showing it relative to mom's age. So it's saying now she has less than the risk that a 20-year-old would start out with. So great news. But that's how these are working. They're balancing risks and chances. They're definitely not giving definitive answers. And what we're going to get for detection rate and false positive rate is going to vary based on a couple different factors. It's going to vary based on things like what lab we're using. Is it a lab that incorporates the nasal bone or is it not? Are we doing one of the first and second trimester combination tests like sequential screen or integrated screening? Or are we just using first trimester screening alone? The accuracy is also going to vary based on mom's age. So, in general, all these screening tests are going to use a cutoff of 1 in 270 or 1 in 250 as the tipping point between a high risk and a low risk. So, for example, if a patient comes back with a risk of 1 in 100, that's going to be considered high risk. If they come back with a risk of 1 in 300, that's going to be considered a low risk. Um, but because the starting point is based on mom's age, the detection rate and false positive rate is going to vary with age as well. So, to give an example to help illustrate this, if you have a woman who's 25 and a woman who's 40, they could have the exact same measurement on ultrasound, they could have the exact same values in their blood work, but the 40-year-old woman's going to get a much higher higher risk result at the end of it than the 25-year-old would because of what their starting points are. In general, the detection rate that we're going to see from this kind of screening is between 75 and 80% detection of babies who do have Down syndrome. And in general, about 3 to 5% of patients are going to receive a false positive. A false positive being a time that their test comes back in the high risk range. They pursue further testing, like cell-free DNA testing or amniocentesis, and those results come back low risk, and their baby doesn't really have Down syndrome or trisomy 18. So while 3 to 5% of women is not a lot, if you consider that 5% is 1 in 20 women, at UConn there's probably more than 20 women in our waiting room on a busy day at the office. So 1 in 20 women is quite a few women who are going to be receiving a high risk result to find out that their baby doesn't actually have this condition in question. So that's where the pre-test counseling is very important in preparing patients for what exactly this test tells us. Hopefully it's saved many of our patients who have received higher risk results anxiety when they get their results in knowing that this is definitely not a diagnostic test. So then what evolved from all that serum screening is our most current version of aneuploidy screening, cell-free DNA testing. And this is what I spend most of the day talking about. This is what most of my patients end up pursuing in their pregnancy. So cell-free DNA testing, I would bet you've all probably heard of it before. But it's using small pieces of DNA that have come from apoptotic placental cells, have been shed into maternal serum. And those small pieces of DNA are sequenced using massively parallel sequencing, and the abundance of the chromosomes of interest is looked for. So pretty much all cell-free DNA tests, regardless of what lab you're using, all of them are looking at chromosomes 21, 18, 13, X, and Y. And then you can get some variation from lab to lab in things like what method they're using for cell-free DNA testing. Many of the labs use a counting methodology. One of the labs uses SNP technology to do their assessment. Some of the labs look for other conditions as well. I believe all of them look for sex chromosome aneuploidies, such as Turner syndrome and Klinefelter syndrome. Certainly the lab that we use does. And many of them also have options for doing microdeletion syndromes like 22q deletion syndrome. Some of them have expanded panels that include other microdeletion syndromes. And then there is a test that looks at cell-free DNA for all 24 chromosomes. And claims that they're able to report on smaller chromosomal changes as long as it's bigger than 7 megabases. So part of our behind-the-scenes role as prenatal genetic counselors is to evaluate these tests, see what claims they make, see what research is available on them, so that we're also offering the best testing to our patients. And this kind of testing is available after 9 or 10 weeks of gestation. And after that, there's really no upper limit on the gestational age that a patient can have this testing. So, unlike serum screening, which has pretty clearly defined gestational ages when patients can have their blood drawn for that screening, this is much more open as long as the patient is far enough into her pregnancy. And where this was really paradigm changing for prenatal genetic screening is that this is the most accurate screening test that we've ever had for aneuploidy screening. So with this kind of testing, we're getting a very high detection rate. So for Down syndrome and trisomy 18, I believe all the labs uh, report that they have greater than 99% detection for those conditions. Um, some of the labs report greater than 99% detection for trisomy 13 as well. Some of them report a little bit lower, but still greater than 90%. There's also a very low false positive rate. So, of all the women who take the test, fewer than 1% will receive a false positive. So this is really an excellent screening test. The problems come in when people try to use it like a diagnostic test. So some of the things that we have to help both patients and providers with is what exactly the information that these cell-free DNA tests are giving us. So where I ask in this last bullet point, is this test diagnostic? The answer is a resounding no. And what we really need to consider is the positive predictive value. So the positive predictive value, you can pull that formula, but incorporates both the sensitivities and the specificities, and also what the a priori or what the patient's risk was for that condition in the first place. So overall, if we look at all the conditions together, cell-free DNA testing has about an 80% positive predictive value. Or put another way, for every patient who gets or for every 10 patients who get positive cell-free DNA results, about 8 of them will be true positives and the other 2 will be false positives. And I really encourage you in your prenatal sites to sort of crunch through some of these numbers. That was one of the things that really helped me understand screening, was to think about, if you change the starting risk, how will that affect the positive predictive value? That helped me sort of think through some of these mathematical screening conundrums. The Perinatal Quality Foundation has a positive predictive value calculator that you can use with cell-free DNA testing online. That's a tool that I and other prenatal counselors definitely use when we get positive or high-risk cell-free DNA results. And another factor that will affect the positive predictive value is which of these conditions are we talking about? Because the more rare the condition is, the less likely that a high-risk result will be to be a true positive. So, for example, for Down syndrome, which is the best performing condition with cell-free DNA, a high-risk cell-free DNA result for that one is much more likely to be a true positive than a high-risk result for trisomy 13 would be. And cell-free DNA is something you're very likely to see a whole lot of in your prenatal rotations. Like I said, this is definitely the test I think about and talk about most. And right now, I offer this to all my pregnant patients, both high-risk and low-risk patients, and about 90% of my patients do pursue cell-free DNA testing. So, what is the genetic counseling role in this aneuploidy education? I've broken it into 4 different areas: providing education, providing support, coordination, and individualization. So, with education, helping the patient understand what is this test, what information does it give you, how accurate is that information, what conditions does it look for, and do they have any familiarity with those conditions? Many people have familiarity with Down syndrome, but for trisomy 18 and 13, most of my patients haven't heard of those before. So giving them sort of a brief soundbite on what those are, so that they know what they're being screened for in advance of their screening. If the test comes back low risk, what does that mean? If the test comes back high risk, what does that mean? and what would the next steps be for either of those possibilities. So, providing them with that education that they need to be able to make an informed decision about what testing to pursue. Giving them support in terms of, is this testing you want in your pregnancy? And when I list these questions, these support questions are listed as if they're directed at the patient, but of course you wouldn't read all these out like you were interrogating the patient. So these things might come out over the process of having a conversation with them, answering how might this help you, or would you find this information useful, or how would you feel if you got a high risk result? Would you change the management of your pregnancy if you found out your baby had one of these conditions? Or how would that kind of information change pregnancy for you? And then we provide coordination in a lot of logistical ways as well. So, ensuring that the correct clinical information goes out to the lab who might be performing the test. Things like the correct gestational age, or correct information about the patient's pregnancy history. Because if they've had a previous pregnancy with a chromosome condition like Down syndrome before, that impacts the chance that this pregnancy would be affected. So making sure all that information is correct so that they can get the most accurate results on the other end of things. Um, Very logistically, doing their paperwork, providing them with the instructions, and giving them information about when we're going to get these results back, making sure we have the right contact information for the patient. And then finally, individualization. So making sure that this is the right testing for the patient. Um, and making sure that we're giving them education in a way that they can understand it. So, some of my patients are very highly educated. I've seen people with PhDs in genetics before, and some of them have a sixth grade education. But both those patients are being offered the same kinds of tests, so they need the information in a way where both those patients will be equipped to use the information to make the right choice for themselves and their families. And we can't use a one size fits all approach to that. We're also addressing what concerns do you have in this pregnancy. So you may be there to provide aneuploidy education, but the patient might be in an abusive relationship, and aneuploidy education is just the absolute last thing on their mind. Um, and like I said before, if something's very important to our patient, then it's important to us as well. And then making sure that the patient is getting information that's helpful to them and that's consistent with their goals and their values for the pregnancy. And all of that comes down to being an advocate for our patients. As a genetic counselor, we can be unique among healthcare providers in believing that these kinds of screens and testing are not one size fits all. And we might be explaining to other providers why a patient is choosing a testing strategy that they're choosing. But to get to know a little bit about them so that we can advocate for their decisions is a really important part of our role. And in all four of these areas, we can take these and apply these to any of the kinds of tests that I'll be talking about. And I won't walk through all of these 4 steps for each one of these tests. But for anything we offer the patient, giving them support in these 4 areas is really important. And moving from that foundation and applying it to all kinds of tests is something that is in our skill set. So, then to move into talking a bit about prenatal diagnostic tests, in the first trimester, we have chorionic villus sampling. And where this differs from first trimester screening or cell free DNA testing is that this is diagnostic. So, this is giving us a definitive diagnosis about whether the fetus has a chromosome condition or not. And when we have a patient who's pursuing a test like this, which we call CVS, just as part of the acronym SOUP of medicine, some of the things we're counseling on them on are the risks versus benefits of pursuing testing like this. So the benefits in being the information that they could get, the risks in the risk of just doing the procedure itself. And so we'd be talking about the risk for pregnancy loss. When you go to your prenatal rotations, definitely ask the providers, both the genetic counselors and potentially the maternal fetal medicine doctors as well, what kind of numbers that they like to use as the risk for pregnancy loss are. You can hear different things from different providers, so that's something to think through as you think about how you'll counsel patients in the future. Many providers for CVS use a 1% risk for loss. Other providers will quote that risk as lower, such as a 1 in 300%. Oh, excuse me, a 1 in 300 chance. As counselors, when we do pretest counseling for CVS, we're also establishing the patient's expectations. So, telling them what they might expect out of this procedure, what the process will be like. One of the things I often tell patients about is about the post or pre-procedure fanfare. So all of the preparation that happens in the ultrasound room where the CVS happens before the actual procedure itself. So I tell them about how they'll start out by doing ultrasounds. The ultrasound will look at the location of the placenta, which is what we're biopsying with the CVS. That will spend so much time making sure that everything is clean and sterile, and that the actual procedure time is just a couple minutes long. So that way they know a little bit more about what to expect when they go into the ultrasound room, and we've demystified the process a little bit. And we'd also be doing pretest counseling of what tests are going to be done. So oftentimes when CVS is pursued, we're going to be getting a karyotype on the back end of things, these being normal male and female or female and male karyotypes. And then we'll be disclosing these results once we get those. During CVS, we might also do a microarray for a more in-depth look at the chromosomes, or a higher resolution look at the chromosomes. So we will often be offering patients the option to do microarray along with a diagnostic procedure like CVS. We'll talk about how with microarray you get more information about chromosomes. You can get more detection of chromosome conditions and ones that are too small to see in karyotype. But we also need to talk about the potential for things like variants of uncertain significance, which we don't have a good interpretation for when we get those back. In the second trimester, we have non-invasive options for testing. We can definitely do cell-free DNA in the second trimester. And then there's some options for serum screening as well. So if a patient's pursued first trimester screening with the HCG and PAP-A, then in the second trimester they might do part 2 of that screening. And if they're doing a part 2, then that would be a sequential or an integrated screening part 2. And what that does is throws a few more hormone or protein markers into the mix, combines that with the results they got from first trimester screening, and just overall brings up the detection rate and brings down the false positive rate of that. Again, many of my patients are pursuing cell-free DNA testing, so there's no need for a part 2. And in that case, when they have pursued cell-free DNA testing, they'll have something called MSAFP. And what that AFP is just one of the hormones, looking at the level of that, because having increased AFP is a marker for spina bifida, or an open neural tube defect. In general, when the second trimester screen is called quadruple screening, it means that that's the only screening that the patient's had, that it's not being combined with first trimester screening. And quadruple screening alone is using 4 hormones or proteins, one of them being MSAFP, to screen for Down syndrome and trisomy 18. And 10 years ago, or is that too long? Many years ago, quad screening was a very common form of screening in pregnancy for aneuploidy, and now it's sort of been replaced for most patients by more accurate options like first trimester screening, or a combined first and second trimester option like sequential screening. But sometimes quad screening is still used if a patient doesn't get to the doctor's office until the second trimester in pregnancy, the limitation being that it is a less accurate screening test. And by the way, that when I talk about AFP and it's MSAFP, what I mean by that is that's maternal serum AFP. So measuring the amount of AFP that's in mom's blood. And that AFP is a protein made by the fetus. For diagnostic tests in the second trimester, we have amniocentesis. Amniocentesis has been around for a really long time, since the 70s. So it was the first kind of testing that people did for aneuploidy in pregnancy. A lot of our pre-procedure counseling has a lot of similarities to CVS. So, setting patients' expectations, talking about risks versus benefits, discussing the risk for pregnancy loss following amniocentesis. Amniocentesis is thought to carry a bit of a lower risk than CVS. You can get some controversy on this. So, for example, ACOG, or the American College of Obstetrics and Gynecologists, says that the risk for loss following CVS and amniocentesis is about the same. They say that's about a 1 in 300 to 1 in 500 risk. Um, Practically, a lot of providers feel uncomfortable saying that CVS is the same risk as amniocentesis because it is done at a point in pregnancy where more pregnancy losses happen, regardless of whether or not we do any invasive procedures. So it's a little hard for many of us to buy into that CVS would really be, on the same level as amniocentesis. So many times providers will quote a lower risk for loss following amniocentesis than the risk for loss following CVS. And what we're doing here is using a very thin needle through mom's abdomen to take out about 2 tablespoons of fluid that the fetus is surrounded by. This picture is a little disproportionate because that syringe and needle are absolutely huge relative to that woman, and such is not the case. Some points that I tell the patient, is that the needle that's used is thinner than the needle used to draw blood out of your arm, and that, as you can see in this diagram, we do watch with ultrasounds the entire time we're doing the procedure so that we always know where we are and where we're going. And following amniocentesis, we are often getting karyotypes. We can also do microarray. Something that I didn't really have time to get into in this presentation was if we do any kind of single gene testing for a family during pregnancy, then they do need a procedure like CVS or amniocentesis. So, for example, if our pregnancy is at high risk for cystic fibrosis, the family will need to pursue one of these diagnostic tests in order to get cells from the pregnancy and test those for the single gene condition. And as a genetic counselor, I'd be helping coordinate that option, explaining those options to the family, all that. And then shifting away from aneuploidy, we also talk about carrier screening in prenatal genetics. And this is something that doesn't have to be prenatal. This could be preconception as well. And in fact, it would be better for almost all involved if patients did have preconception testing. So if they did get their carrier screening done prior to pregnancy. However, that's just not the reality most of the time. Most of the time, we are offering carrier screening during pregnancy. And there's a few conditions where ACOG recommends offering carrier screening to all pregnant patients. Right now, the big 2 are cystic fibrosis and spinal muscular atrophy. And then based on a patient's ethnic background, there might be other recommendations for additional disorders as well. So for example, people of Ashkenazi Jewish ancestry, it's recommended by both ACOG and ACMG, the American College of Medical Genetics, that patients be offered a handful of carrier screening tests if they do have Jewish ancestry, for example, Tay-Sachs disease, also some others like Bloom syndrome and Canavan disease, Niemann-Pick, and a couple others as well. ACOG also recommended in their most recent recommendation that everyone be evaluated for hemoglobinopathies such as sickle cell trait, and that can be done through hemoglobin electrophoresis. We can do some of that screening too through just a complete blood count, which the vast majority of patients will have in their first round of prenatal labs ordered by their doctor. And our modern day is one where there are a lot of options for carrier testing. There's a lot of options for expanded carrier testing as well, which is where we're screening simultaneously for many recessive and X-linked recessive diseases. So there's a lot of different commercially available options, ranging from anywhere to screening for 3 diseases to screening for 300 diseases. I don't routinely offer those 300 disease panels, but what I offer many of my pregnant patients is a panel of 4 different carrier screening conditions: cystic fibrosis, spinal muscular atrophy, Fragile X syndrome, and Duchenne muscular dystrophy. I make that available to all of the internal referral patients that I see who haven't had carrier screening in the past. Um, and again, like all the screening and testing we talk about in pregnancy, carrier screening is not mandatory during pregnancy. So if a patient wants to decline any and all of the screening and testing that I've talked about so far, it is absolutely their prerogative to do so. And I would act as their advocate for why they had come to that decision. So then to talk a little bit about results disclosure, I'd probably do some kind of results disclosure almost every day. Most of that is good news results disclosure. So, yay! um, so there's so much to talk about with results disclosure. You'll talk about it so much in your training. You'll also see so much of it as you go into clinical internships. Some of So I just have a couple points here for results disclosure. When it comes to prenatal genetics and good news results disclosure, some of the things we have to keep in mind is to avoid overselling good news. So even though things like a normal cell-free DNA test or a normal serum screening or even a normal CVS or amniocentesis are great news, they are telling us specific information. So even a diagnostic test like amniocentesis, it is telling us about the chromosomes, but it's not telling us about everything that could go wrong in a pregnancy. So as providers, we just have to choose our words carefully in terms of what we relay to patients when we give them good news. That doesn't mean we can't be happy with them. It doesn't mean we can't celebrate with them. But we also have to be careful not to make any promises that we wouldn't be able to uphold. Another thing you might hear providers shy away from is ever saying that something's 100% accurate. I would never say that something's 100% accurate. We do need to keep in mind that at the end of the day, any test that we offer is a test that's done by humans. So there's always the potential for a human error in there. And with good news, with bad news as well, we also have to put that news into clinical context. So, for example, someone might have an amniocentesis for news that was already bad, like a congenital heart defect. And that amniocentesis might come back and reveal normal chromosomes. And while that's not bad news, it doesn't change the reality of what we saw on ultrasound. So, helping patients understand how the result that they're getting fits into the whole picture of their pregnancy and looking at that whole picture in our interpretation of the results is really, really important. In terms of giving bad news, I definitely won't tell you everything you need to know about that today. No one could tell you everything you need to know about that in one day. But some of the things that you can be thinking about in terms of giving bad news are the words that you choose with which to give it, the sensitivity that we need to have for our patients when we are giving them bad news, and also for following their lead in what they perceive as bad news. So, for some people, when I've told them about something like a 1 in 200 risk for Down syndrome, I've had some patients react very dramatically. They've been, deeply concerned about it, very affected by that, very shooken up by it. And one time I told a patient her risk for Down syndrome was 1 in 15, and she was like, oh, that doesn't sound so bad. So risk perception is a really complex topic. And how patients react to bad news is determined by lots and lots of factors in their whole life, not just what we've met of them so far. So being sensitive to how their reaction is, and letting them have their reaction, even if a provider might think that that's an over or an under reaction to what we're telling them. We also need to avoid overselling bad news as well. So many higher risk screens do end up being false positives. So we need to be open to all those possibilities with patients. With any high risk test result, we're never an oracle into how their pregnancy is going to turn out. So sometimes when patients say, I hope the test is wrong, it took me a while to get to this point, but I got to the point where I can say, I hope it is too. I hope everything's okay in your pregnancy as well. And realize that that didn't mean that I was saying, oh, our tests are crappy because I was saying that. Putting bad news into clinical context as well. So, putting the many pieces of the puzzle together, like what did ultrasound say, or what was your risk starting out, and then providing patients all the support and education that they need to walk them through that process. So that definitely is a process. Bad news in pregnancy is really bad news. So even though most of our news is good, when we really have bad news to deal out in prenatal genetics, it is very bad news. And then empathy is such an important part of being a counselor. So to understand our patients, to get to know them a little bit as whole people, um, and listen to them when they talk about, what their thoughts and feelings are on the situation, and the factors in their life that shape those feelings. And when bad news comes, sometimes that does lead us into a prenatal diagnosis of a condition. And what we can do in that situation is, again, to give them all the support and scaffolding that they need, to provide them with a balanced education about whatever diagnosis that we're speaking of. So, to use Down syndrome as an example, to not just paint Down syndrome as a list of symptoms or features, because that's a pretty poor representation of what someone with Down syndrome is like. But to give a family resources that shows what a family's life with Down syndrome might be like. Um, to use patient-centered or person-centered pictures of people with genetic conditions. A lot of the old school pictures of people with genetic conditions sort of depict the person as, naked in their doctor's office, thrown up against a wall. And really, we'd all look pretty unfortunate in that scenario. One of the resources that's really helpful for us in Connecticut is that we do have a program called the First Call program, which is run through the Connecticut Down Syndrome Congress and gives newly diagnosed families who have prenatal diagnoses of Down syndrome, that lets them connect with a family that has a child with Down syndrome. So that's a really nice resource for us. At the same time, you know, we do seek to tell people about the difficult parts of a prenatal diagnosis. So, what complications that might bring with it, what extra surveillance their child might need in pregnancy or during their childhood. So, to paint a very balanced and transparent picture. And then, in terms of a family's management options, to make sure they are offered all of their management options and that we present those in a non judgmental way. So that we do talk to them about the option of continuing a pregnancy. We do talk to them about the option of pregnancy termination, and we do talk to them about the option of adoption, and that we present all those options as, valid options that they can choose and that we will support them in. So whatever decision that they make, we will be there to give them what they need. And again, that just speaks to being an advocate for our patients. Um, Probably more than any other decision when it comes to testing or pregnancy, um, termination and continuation of pregnancies are ones that are just so individual and so value driven, where there really is no one size fits all answer. That our non-judgmentalness and non-directiveness is just of the utmost importance when it comes to this. And with all of these options, patients will always feel judgment and pushback from other people, regardless of the choice that they make. So, patients who terminate pregnancies feel very judged by other people for making that decision. But patients who continue pregnancies feel probably the same level of judgment as well. So, it's a decision where there's always going to be a loud dissenting opinion that the patient feels from people close to them or from society in general, or even from something like morons on the internet. So, being a touch point for a patient, someone who's on their side, regardless of what their decision is a real honor for a prenatal counselor. One time, in very early in my career, actually, the first prenatal diagnosis that I had was a young lady whose baby had trisomy 13 who decided to continue her pregnancy. And it was about midway through her third trimester when she called me one day and said that she felt like all the doctors she spoke with just had no regard for her son's life. And one of the things she said that just gave me chills was they talk about him like a bug that needs to be stamped out. And it was, it was so devastating that she didn't feel respected or cared for by those people. But at the same time, it was a really big honor to be able to know that the relationship I had established with her was one where she knew that she could call me and that I would listen to her as she talked about those things. So that's something that I really cherish. Um, as much as I love to give good news, and I absolutely do, walking alongside our patients who do have bad news in pregnancy is something that's really special about being a prenatal counselor. It's really special to be a part of someone's life when they do really need us. Um, and and for many of my patients who've terminated pregnancies, um, seeing from their perspective what that loss is like for them, I find that it's very common for patients who do choose to end their pregnancy for prenatal diagnosis um, to regard that pregnancy loss as just that, as a loss. So the same that a family would grieve a baby who had died, or who had been stillborn. And for many of these families, the babies that they've lost really are children to them. They do give them names. They do honor their memories. Um, they've they've been in a situation where they have no good decision and they had to choose, what would be best out of two crappy decisions. So again, that's getting to be with those families during those times is something irreplaceable to me. In terms of options for termination, this is something I know that all of you as students are really spread out, and this is something that can be really different geographically depending on where you are. It's important as a practicing counselor to know what the laws are in your area in terms of gestational age, what the availability of providers is who do these procedures. Knowing those things is really important for your patients because many patients who are choosing termination never thought that they would need this kind of information. In terms of gestational age, this is going to be stable regardless of where you are. Some of the options for procedures in the first trimester, dilation and curettage is usually the procedure for termination of pregnancy. This is probably the time of pregnancy when the least amount of terminations happen for genetic diagnoses, because this is very early in pregnancy, usually too early for us to have been able to make a diagnosis. So, most of the time when we're walking patients through their options for termination, we are helping them, we are weighing out the options of doing dilation and evacuation or D&E or having an induction. Sometimes you'll hear doctors call a D&E the surgical option and an induction the medical option. Those aren't really my favorite words for those procedures. I think surgical makes it sound more like surgery than it is. And I think medical doesn't quite capture what an induction is either. A dilation and evacuation, though, is a procedure where typically or almost always the patient is under anesthesia, and the doctor does the procedure where they'll remove the fetus's body. And that's usually a 2-day process. The first day where they put laminaria or seaweed sticks into the patient's cervix to soften and dilate her cervix, and then the second day when the actual procedure happens. And an induction is when a patient is given medication that will induce uterine contractions and induce labor, and then the fetus will be delivered. So, with those two, helping patients weigh those two options, I find in my practice, and this is just my personal experience, I find that people are usually absolutely horrified by one of those options, but it's not always the same option. The hard thing with induction is that the patient does have to go through labor. Um, they do have to deliver their baby. Um, with dilation and evacuation, the hard thing can be that the patient can't see their baby after the procedure happens. Induction also offers some options like autopsy or testing after the procedure. So there's some benefits and limitations to both those options. And when you're in your prenatal clinics, you can learn much more about those procedures from your counselors. So we've talked about quite a lot today, but like I said, it's really just scratching the surface. When I was asked to do an hour-long presentation on prenatal counseling, I was like, "What am I going to talk about?" Because I could speak about this forever. I could talk about this until I'm blue in the face. Um, so I just tried to give you a primer. There's a lot of things I didn't go into today, but like I said, you'll be learning so much in your clinical rotations. I'm so excited for you. I'll give you a little unsolicited advice about going into your prenatal rotation. The first piece of advice is about speaking with patients in general, um, and it's just to always meet the patient where they're at. So if they have an unrelated question, to address that first, to never be too married to the script that you might have for the session in your head. And to always be on the patient's level in terms of the education you give them. Because education that's not on their level is oftentimes not going to help them. And then, in specific to you being a student, see everything with everyone. So watch ultrasounds, watch CVSs, watch amniocenteses. Um, if the opportunity presents itself for you to watch a termination procedure, take that as well. Everything that you see is going to give you some perspective that can help your patients. So even if it's something that, we're fortunate in that when we watch amniocentesis, we don't have to watch it through the lens of, hey, I'm going to do this someday. But seeing what those procedures are like give us such good insight to pass along to our patients. So just try to see everything, and also really get the perspective of other providers, not just the genetic counselor you're working with. Of course, you're going to be like just steeped in his or her perspective, but speak to the doctors and the sonographers that you meet with, and understand the angle that they might be coming from. We really are all a team with prenatal care. We all have our different perspectives, and all those perspectives are important. So just ask questions and listen. Listening is just great advice for both being a student and being a counselor as well. And then also collect phrases. Um, as you think forward to being a counselor yourself, listen to the way that other providers talk to patients. And you might hear a provider say something where you say, like, hey, I really like that. Just collect those phrases, collect them in your mind, write them down. And what you end up with is kind of like a potpourri of phrases that speak to you and that help, that come together to be kind of a mosaic of the counselor that you end up being. So, in conclusion, I think prenatal counseling is wonderful. And like I said, this was really only a highlights tour of some of the things that we do. The best of luck in your rotations. I know at least one of you is coming to prenatal genetics. But when you see prenatal genetics, I hope you enjoy it as well, and I hope you enjoy your other rotations also. If you'd like to contact me, that's best done through email, and this is my email address. It's my last name, which is gancars@uchc.edu. So thank you so much for sticking with me today, and best of luck.